First of all, welcome. This is the 5th annual symposium that we have held. It's the 5th year in a row. It is a program that has been ongoing at UCLA since 1998. And this year we felt like everybody needs to go back to basics and just know what we're dealing with. And we're obviously dealing with a devastating cancer.
This session was basically designed from the input from last year that quite a number of you, when we're talking about fantastic research going on the pancreas, what is actually the pancreas does, 101.
First of all, in this little graphic right here, we see the gastrointestinal tract, and here's the esophagus coming down here, and I've got it below up here, esophagus going to the stomach, and then here's the first part of the small intestine called the duodenum, and in the yellow is our pancreas. There are two major parts of the pancreas. One is the endocrine, and it regulates our metabolism, and the other is exocrine, and it regulates the digestion of our food.
Generally speaking, most people who are diagnosed with pancreatic cancer die within the year of diagnosis. And so those numbers with regards to new diagnoses and death rate are fairly equal.
The disease starts to appear in the 40s and 50 age range, but then increases with age. The genetic factors underlying pancreatitis accounted for about 15% of this incidence. Smoking 25%, obesity, inactivity 15%, dietary factors 35%, and pancreatitis and others 10%. Most of it is some way or another environmental. Those are things that we're acquiring during our life, either from dietary and smoking habits, or maybe pancreatitis.
Inflammation plays a major role in the initiation, the early development and progression of cancers. Chronic pancreatitis, either caused by heavy drinking or some genetic mutations, can cause or can increase the risk of developing pancreatic carcinoma. And this is a table which shows you certain infectious agents which can cause chronic inflammatory diseases, which increase the risk of developing cancers in that organ. Besides these infectious agents, there are other factors, including environmental and dietary factors, which can cause chronic inflammation and tumors.
In fact, alcohol abuse is one of the major causes of scarring in the pancreas and liver. It mediates cirrhosis, and this shows that alcohol abuse activates this cell, which has effects both on the liver and pancreas. And the other thing I want to point out in the pancreas is that tobacco smoking is a key activator of this cell as well.
About 15% of patients with pancreatic cancer are candidates to go to the operating room. And currently, it's thought that the only chance for cure is to remove the tumor. 51% of patients with stage 1 disease never make it to the OR, never were offered a surgery. So the next trick is going to be able to figure out how to do early detection so that more people can go to the operating room.
There's still a lot to be done with respect to the early detection, because I think we all believe that that's where a lot of the future lies and promise lies in pancreatic cancer. First question is, what disease stage are we hoping to detect?
We're looking to see what the relationship is of the tumor to all of these structures. The tumor is confined to the pancreas, then it's a T1 or T2 tumor, but when it grows to the duodenum, a T3, and then to these blood vessels, a T4 tumor.
And the question is, do we have any blood markers or juice markers right now? And the short answer is, no, we don't. And perhaps in time, we'll have blood-based markers, and we'll be able to say to a patient, you know, not only do you not have an invasive cancer, but we think you have an early lesion that if we have surgery or some form of therapy now, we'll be able to manage.
Gemcitabine has been the standard treatment over the last decade. Gemcitabine, fortunately, is fairly well tolerated as a chemotherapy. Unfortunately, it's not nearly as effective as we would like, and that is, I think, something that that many of us, unfortunately, are familiar with. There recently have been studies of 2 agents that have shown additional benefit over gemcitabine alone in large randomized trials. The 2 agents are capecitabine and Xeloda, or erlotinib, or Tarceva.
And part of our approach to general populations is simple, non-invasive, broad screening that might even just whittle down the pool for further screening. And so one of the approaches we've taken with this is in conjunction with David Wong, who presented here about 2 years ago, salivary diagnostics. So this is just another area of diagnostics, but the attractiveness of this is that it's a very non-invasive, simple approach. So it's not blood tests, and might be a very simple way of whittling down a large group of patients.
It takes a huge effort, both in terms of people and in terms of funding, in order to do any sort of clinical work.
And it is really the lowest of all these sort of major malignancies that are funded through the NCI. And I know Aggie showed this slide, but we're going to drive it home one more time. And this is really the dollars.
We are number 4 on the list for both men and women. Of course, the disaster as far as where we are in funding. 11th in number 1 cause of death, and 4th of all cancers is not acceptable. It is only private funding that is the engine for research. The more seed grants, the more early projects we begin, the more we can suffocate the pipeline for receiving funding and getting this rate up. So we have a lot more work to do. Sometimes it's tears, but sometimes it's plain old facts that makes us angry and keep on pushing. I think the most important thing that I keep saying every year is 12 years ago, I and my very small group, which is now a very large group, committed to be the financial partner to the researchers that are going to cure this disease, and we remain your financial partners until we can detect the cancer early, offer treatment options that are meaningful, and a pain-free full life.